So just a few things before we jump right into this video. About a year ago, I thought to myself, maybe let me start making some videos teaching certain topics. That's how I decided to go ahead and get some courage to actually post a few videos on the channel and actually create this channel. It's actually the channel's birthday today, so a big happy birthday to the channel. The channel turns 1 year today, and coincidentally, yesterday it was a few days ago, we actually reached the 2,000 subscriber mark. So a big shout out to everyone that subscribed, that keeps on supporting the channel, that keeps on watching the videos, liking the videos, commenting on the videos. You guys are all my superhero. We will continue to look forward to more contents on the channel. I'm back to recording videos now, and I will be giving you some contents on the newer topics and some other aspects. We will be doing a few live streams here and there, depending on how much time I have on my hand. So grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at something that has been rather trending over the world because we're getting some cases of it. This is, of course, monkeypox. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a comment, drop a like, and let's go. So, to give you just a background about the epidemiology of this condition. Now remember that the first ever case that was isolated of monkeypox was actually discovered in the Democratic Republic of Congo. That was roughly around 1970. So this was actually a 9-year-old boy that developed this smallpox-like illness, and it was later on called monkeypox. Now similar cases were actually seen in the 1970 to 1971 in the Ivory Coast, in Liberia, in Nigeria, and even in Sierra Leone. Initially, the monkeypox was actually just limited to countries that had rainforests in the central and well as Western Africa. And not until the year around 2003, when we had the first cases that were actually discovered in the Western Hemisphere. We had some cases also, isolated cases later on, that were also discovered in the US. Then in July 2001, we had a case of monkeypox that was reported in Dallas, Texas. This was just a traveler that had gone to Nigeria. And there was a second case that was reported in Maryland, another traveler that was returning from Nigeria. So it seems like most of these cases actually came from Nigeria. Then currently, we have over 100 cases that have been confirmed of the virus. That is obviously causing a rash, it's causing a fever. And these have been confirmed in Europe, they have been confirmed in America, they've been confirmed in Australia. And the number actually is expected to rise, but overall, the risk of it becoming like a huge pandemic like we're having with the COVID pandemic is not as high as we have with the coronavirus. So it's not really as infectious as the coronavirus, though the virus originally came from the Central and West Africa. Now we have actually even detected the virus in over 16 countries outside Africa, and this is actually the largest outbreak of monkeypox outside Africa in 50 years. So a little bit about the biological information. Remember that this falls to the family that is known as a pox viridae. The genus is Orthopox. There are some other members in the same groups, cowpox, vaccinia, as well as a variola, which is the smallpox. Remember that we developed a vaccine for smallpox, and we have actually aimed to eradicate smallpox, and it's actually done very, very well. Now, when it comes to monkeypox, it's a zoonotic virus, meaning that it is transmitted from animals. Now, many people think that, okay, if it's monkeypox, then obviously the reservoir must be monkeys. It's not as easy as that. If science was as easy as that, we would all be Albert Einstein or someone who's really smart in the science department. But that's not how it works. So the virus was actually named because it was first isolated from laboratory monkeys in the year 1958. That's why we call it as a monkeypox. Now, reservoirs are not really known, but what we have learned is that some candidates include things like small rodents like squirrels. You may also have rats. You may have rabbits. You may have porcupines, gazelles, and to some extent, even monkeys can actually transmit the infection to humans. Then it's much common in the rainforests of Africa, mostly Western and Central Africa. And there is no predilection for gender, so there's equal affectance of both male and female. There's no predilection for race, so all races are affected. And most commonly, we see that this affects children, most of the children being below the age of 15 years, but any age can actually be affected by this virus. Now, how exactly is it transmitted? This is going to be through the contact of animal body fluids. So it could be saliva from an animal, it could be respiratory droplets from an animal, it could be contact with wound exudates of an animal. And remember that on the human, there should be a break in the skin, or you should have contact with the mucosal membranes, your mucosal membranes, meaning you touch the saliva of your dog, you don't wash your hands, you rub your eyes, you put your fingers in your mouth, and that's how you get the virus. Potentially, it can also be contracted via ingestion of inadequately cooked meat. So pretty much like your rabbits that are inadequately cooked that have the virus. This could also be a potential route of transmission. And also person-to-person transmission occurs, but this isn't really efficient. It's not really like the usual person-to-person transmission of other types of viruses. But what we really think is the cause, it's really the transmission of large respiratory droplets via prolonged face-to-face contact. Could also have direct contact with the mucocutaneous lesions, or even fomites can actually transmit the virus. Now, here's a bit about the pathogenesis of the condition. Remember that the virus is pretty much going to be infecting the area, either the mucosa, or it can be infecting maybe a break in the skin. So it's going to be replicating and multiplying at the primary site of the infection. So this is obviously going to give you a local inflammatory response. Then it may spread to the local regional lymph nodes and cause those lymph nodes to swell up. This is the hallmark of smallpox. That's how you differentiate it. Monkeypox. That's how you differentiate it from smallpox, because in monkeypox you have the lymphadenopathy. In smallpox you do not have the lymphadenopathy. So it may also further spread to distant lymph nodes. It may also spread directly with primary viremia, where it gets into the bloodstream and then spreads to other lymphatic organs like the spleen, like the tonsils, and causing these organs to undergo lymphoid hyperplasia, where they begin to proliferate and these organs may enlarge. So you may get lymphadenopathy, you may get your splenomegaly, you may get enlargement of the tonsils. In some severe cases, it may actually spread to the brain and may actually cause an encephalitis. So it may have that systemic spread with secondary viremia. So it may first spread to the lymph nodes, so it gets into the bloodstream, then spreads to the lymph nodes, it gets into the bloodstream again, where it involves various other organs, which are referred to as the skin, the eyes, the GIT, so on and so forth, giving you the clinical disease. With, of course, an incubation period, according to this schematic here, of about 7 to 17 days, but generally it's about 4 days to about 20 days. Now, of course, you may get your mucocutaneous lesions, which I will show you. You may get some systemic tissue injury and even antibody formation. Now, our incubation period averages about 12 days. So like I said, it's a range of about 4 to 20 days. Now, there are stages of the disease. There's what is known as the prodrome, or the pre-eruptive stage, before the actual lesions, the skin lesions, show up. And there's what is known as the exanthem stage, or the eruptive stage, when the skin lesions actually show up. Remember that there are two concepts that I want you to remember: an exanthema and an enanthema. An exanthema is just pretty much a sudden rash or a breakout in the skin. Most of them are attributed to viral infections. Then, of course, an enanthema is a sudden eruption or rash on the surface of the mucous membrane, which is usually in the mouth or the pharynx. Now, monkeypox is very similar to smallpox. The distinguishing feature, like I told you, will be enlarged lymph nodes, the lymphadenopathy, especially the submental, the submandibular, the cervical, and the inguinal lymph nodes. I'll show you pictures of some of these lesions and what the lymphadenopathy rather looks like. Now, you may also get enanthemas, you may get non-specific lesions, you may get inflammation of the pharynx, the conjunctiva, even the genital mucosa in some isolated cases. Now, in the prodromal phase or the pre-eruptive stage, this is going to be lasting about 1 to 2 days. And you're going to be having fever as the first common thing. And of course, fever occurs in many conditions. It occurs in some parasitic infections like malaria. It occurs in some bacterial infections. So it's rather non-specific. So our fever is usually going to be around 38.5 to 40.5 degrees Celsius. Of course, this should be in the background of traveling to a country that is endemic for monkeypox, or being in contact with someone who was found to be positive with monkeypox. Then, of course, a febrile illness is going to be accompanied by chills, drenching sweats, which are very similar to malaria if you're looking at this, severe headaches, backaches, myalgias, malaise, anorexia, prostration, pharyngitis, shortness of breath, and a cough, which may or may not have sputum. All these are just non-specific symptoms. Now, lymphadenopathy is what's going to be now developing 2 to 3 days after the fever. And that's what will give you the hint. The lymphadenopathy, the fever, first of all, the lymphadenopathy, and the characteristic rash that comes out. Then most likely that this person is a good candidate to have monkeypox. Then in the exanthem stage or the eruptive stage, here the rash is going to develop within about 1 to 10 days after the onset of the fever. Then of course the rash usually starts off on the face, then spreads to the rest of the body, though it doesn't really follow a centrifugal type of distribution as we see characteristically in smallpox. Now, it's going to persist for roughly about 2 to 4 weeks until the lesions actually shed the crusts, and then you may also have encephalitis with immunoglobulin M formation in, of course, the CSF. We have seen this in some number of cases. Now, in the exanthema stage, within the particular body region, you're going to be having this rash, and of course, the lesions evolve synchronously over 14 to 24 hours. And unlike smallpox, these skin lesions are actually going to appear in crops, so in groups, and then the lesions are not going to have a strong centrifugal distribution as we see in smallpox. The lesions themselves are going to be macules. They start off as macules. Remember, macule is a flat lesion. Then they become papules. They become raised. Then they become a raised solid lesion is a papule, less than 0.5 centimeters or 1 centimeter. Then they become vesicles. They get to be filled with some fluid. Then they become pustules, where they get to be filled with pus. They may have a central umbilication, so they may be umbilicated as central, like I could say a depression or a hole. It's very similar to what we see in molluscum contagiosum. Then of course there may be some crusting and desquamation that may follow. Most of the lesions are going to be about 3 to 15 millimeters in diameter, and they're going to be appearing on the face, the trunk, the extremities, the scalp. You may also have necrosis, petechiae, and ulcerations that you may see. Pain is quite unusual to see, but you may get some itching. Usually when we get pain, we want to suspect that there is a secondary bacterial infection, because you may have some itching, you may have some ulceration, you may have some break in the integrity of the skin. So these lesions could more or less be infected with a bacteria. Now, in vaccinated patients, actually, they get a milder form of the disease. So the lesions are rather non-specific. The erythematous papules are about 1 to 5 millimeters, so they are actually rather smaller. Then this is suggestive of an arthropod bite reaction. Like, for example, if you're bitten by a spider, the reaction that you usually get in that area, or you're bitten by another arthropod. Now, the umbilication is rather subtle as compared to monkeypox. So here's a picture of the vesicle lesions, as you can see here. So I'll zoom into this one over here. As you can see here, there's a central area, there's a central umbilicated area there. So these are the lesions, the vesicles that I was talking about. And this one here on the right here is even umbilicated. As you can see, is a central depression over there. Then here are other typical lesions, as you can see. So this is most likely monkeypox. This rather looks like a very, very nasty thing to look at. Now, lymphadenopathy in monkeypox, as you can see, there is some swelling. There's some swelling that we can see over here. Lymphadenopathy is the key feature that's going to help us distinguish monkeypox from smallpox. Now, in some people that are unvaccinated, they may have a confluent area of erythematous eruptions, especially on the face, on the upper part of the trunk. So they may develop what is known as a septicemic rash of monkeypox. You may also get some other forms like a hemorrhagic type of patterns, flat forms, which can be seen in with smallpox, and these have not been related to or have not been reported in patients in those that have monkeypox. Now, some laboratory studies that you can do, of course, your usual baseline investigation. So just your complete blood count, which may show that there is an increase in the lymphocytes. Then, of course, you also want to do your viral cultures from your oropharyngeal as well as nasopharyngeal swabs. You want to get a skin biopsy of the specimen, obviously the vesicular papular rash, or a sample of the roof of an intact vesicular papular eruption. Then, of course, you may also do tissue PCR for DNA sequencing to find the specific monkeypox virus that you can obtain. You can also use a zinc smear, which can help us now differentiate monkeypox from other non-viral causes in the differential diagnosis. Because remember that smallpox is a very huge differential diagnosis that's quite similar to monkeypox. Now, our diagnostic criteria. So if you want to confirm a case, you need to have one or more of the following things. So the first thing is you should isolate monkeypox virus in the culture from a sample that you obtained from the patient. The second thing is that you should demonstrate the monkeypox virus on PCR in the specimen obtained from the patient. The third thing is that you should demonstrate the orthopox virus by electron microscopy in a sample that's obtained from a patient in the absence of exposure to other orthopoxy viruses. Then, of course, the demonstration of a monkeypox virus by immunohistochemical methods in samples obtained from patients in absence of exposure to another orthopox virus. Now, for a probable case, you must have had contact with someone who has the disease, and of course the occurrence of fever, a vesicular papular rash, and with the onset of the first sign or symptom at least 21 days after you have been exposed, then this meets the epidemiological exposure. This is probably a probable case of smallpox. Then a suspected case is, of course, a contact that's meeting the current CDC guidelines. Then, of course, the occurrence of fever or any unexplained rash, and 2 or more signs and symptoms with the onset of the first sign or the onset of the first symptom being 21 days after the exposure. So it includes things like chills and sweats, lymphadenopathy, a sore throat, cough, shortness of breath, headaches, and even backaches. Now, when you do your histology, you'll see a numerous number of things. So when you get histology, the papular lesions may show acanthosis. They may show individual keratinocyte necrosis. They may also show some basal vacuolization. Now, this is more or less often going to be accompanied by certain changes, which are going to be including things like superficial as well as a deep perivascular as well as a lymphohistocytic. So you have the lymphocytes and your histiocytes, which are going to be infiltrating the dermis. Then, of course, the lesions in the vesicular stage, we're going to be demonstrating spongiosis with reticular and ballooning degeneration. You may get some multinucleated epithelial giant cells that may often be seen. The pustular lesions are going to be characterized by epidermal necrosis with numerous eosinophils, neutrophils, of course, displaying karyopexis. Then, of course, you may have necrosis that may actually extend through the full thickness of the epidermis with a sharp lateral demarcation from adjacent intact epidermis. Of course, there is associated perivascular infiltration that's going to be including things like neutrophils, eosinophils, in addition to lymphocytes and histiocytes. In the petechial lesions, these are going to be demonstrating some secondary vasculitis. Then, of course, there may be some amorphophilic intranuclear structures suggestive of a viral inclusion bodies that may be seen in the keratinocytes. So these are just the different things that you see on the histology of patients or the lesions that we see in monkeypox. And of course, the management, the disease is usually self-limiting, so the resolution usually happens in 2 to 4 weeks. In the African cases, the mortality rate was roughly about 1 to 10%, and death was actually related to patients that had a poor health status, patients that had other comorbidities. Then, of course, most deaths are going to be arising as a result of secondary infections or other complications that may be associated with the condition. So in most patients, we advocate for bed rest along with supportive care that may be necessary. We hospitalize and isolate the patients because this is a quite infectious disease, so these patients must be kept in infectious disease and preferably in a negative pressure room. Then there is no proven safe treatment for monkeypox infection, but of course, just the supportive thing like I already said. There are some potential drugs that could be used. One antiviral is a tecovirimat, which is pretty much was approved for treatment of smallpox. And then there's another antiviral drug which is cidofovir, which was also approved, or rather is also being used in the treatment of monkeypox. But we use this pretty much because it inhibits viral DNA production in CMV as well as other herpes viruses. So potentially it may also work in the treatment of monkeypox. Then all of the drugs actually have shown activity against monkeypox in vitro and in some experimental models. However, none of the drugs have been tested and have been studied in endemic areas where monkeypox is rather prevalent. Now, the CDC recommends that smallpox vaccination within 2 weeks of exposure, ideally 4 days for exposed healthcare workers and household contacts of confirmed cases. They should get vaccinated for smallpox as well. Cidofovir has been suggested as a possible treatment option in severe. We usually reserve it for severe or life-threatening cases. We may give Vaccinia immunoglobulin that has not even demonstrating any efficiency or efficacy to work in either treatment or prophylaxis. So those that receive these immunoglobulins, it's just to protect you against Vaccinia, not really against the monkeypox. Then of course there is ST246, which has been studied in animal models which have monkeypox, the monkeypox virus infection, and it has shown some efficacy against prophylaxis, post-exposure prophylaxis, pre-exposure prophylaxis, as well as therapeutic treatment. But then of course in September of 2019, the Food and Drug Administration approved an attenuated live non-replicating smallpox and monkeypox vaccine for, of course, immunization of adults that are at high risk of smallpox or monkeypox infection. So you should get this vaccine. So some complications include a pitted scars. You may have deforming scars. You may have secondary bacterial infections, which may cause pain. They may cause deaths. You may have bronchopneumonias, respiratory distress, keratitis, corneal ulcerations, blindness, septicemia, as well as encephalitis. Most of these complications can actually result in death of the individual, aside the comorbidities that the patient has. Thank you for spending your time to watch this video and learn about monkeypox today. If you haven't yet subscribed to the channel, please hit the subscribe button. Hit the bell notification icon to be receiving notifications of such videos every time I post. My name is Dr. Moses Kazevu. To Zambia and beyond, bye-bye.